So just a few brief words here. So this is the 12th year that we've done this, had this demystifying medicine business. And the intent of it is to try and kind of bridge exciting things going on in basic science with major health problems. And what we try to do most of the time is actually to begin each session with a live patient who explains in plain English what this disease is like that they have, and then that's followed by a more clinical investigator and then by a basic scientist. Now, you don't have to have a huge background in medicine or even much, well, things like histology and whatnot in order to appreciate what goes on. The intent here is not to be like a medical school lecture where you have to write down all sorts of stuff. The intent is to excite, to interest, and to provoke you to think of where areas of your expertise, particularly for the postdocs, which has been the largest group of the audience, where what you know may interact with some of the big problems that are, being presented. And we're very fortunate because here at NIH, there are extraordinary people working on different aspects of this so-called clinical and basic business. And so for that, I've always used the logo of the most famous bridge in the world, which is the Brooklyn Bridge. And those guys actually could walk across much of that catwalk. And the point of it was very simply that life on both sides of the bridge were never the same after you built it. And so the paradigm of the relationship pertains to the big problem that we have of trying to relate the exciting developments in biological and engineering sciences to human health. And that's the purpose here. So, if you're an undergraduate, a medical student, postdoc, PI, administrator, everyone is welcome. And you don't have to, the way you register is to sign up on the listserv, and that then gets you access to various information I'll send around, a biographical sketch of the speaker of the week, very often the PowerPoints and some selected references and so forth, which hopefully you will peruse before you come and have a better idea and appreciate more material that's being presented. The program here is on site. It's online. There are hundreds of people. Last year, the average was 260 who watch on site around the campus. It's on YouTube, and after 3 or 4 days, it's in the NIH video archive where it sort of goes around the world. And you can watch programs over the course of the last 11 years if you want to at your own time. It's kind of interesting, and I find it very exciting, that this approach, which is sort of like what old-fashioned grand medical rounds used to be, has been replicated now in 17 countries and over 24 North American institutions, and that's very exciting. There's no academic credit for those students who've contacted me who want to register and pay tuition and get credit. No problem. There's no credit. There's no tuition. And for those who are looking for clinical certification credits, there's no clinical certification credit, so don't worry about it. If you really want some acknowledgement that you've taken part in this, if you attend about 2/3 of the sessions, register in the book that goes around, and at the end, pass a not too complicated electronic final exam, you'll get a certificate indicating that you took part on it. So we encourage you to ask questions, hopefully ask questions, not make speeches, and enjoy and be excited by what's going on. Any suggestions, comments, criticisms, the better, suggestions for future speakers, et cetera? We really welcome it. Okay? So this is sort of the subtitle, in a way, of today's topic, and it's something that recurs with many of the topics that we're going to have. But probably there's no better example of this than the sort of eternal battle between man, other mammals, and microorganisms. You sort of wonder, we think in terms of, say, an antibiotic that knocks off a certain bacterium, but I've always wondered, when you consider the diversity and the capability of microorganisms to adapt to the enormous changes in their environment and all the chemicals and stuff that we pour into it, as well as the antibiotics, you might look at it the other way around and almost say, isn't it amazing that an antibiotic actually kills certain organisms and prevents diseases? Thank God it does. But it's not an open and shut case. And this is one of the great global problems of drug resistance. So today we're really most fortunate to begin this series by having two speakers who are very much at the forefront of work and thinking about this. Our first speaker is going to be Tony Fauci, who's known, I'm sure, to all of you. He's the director of NIAID. He trained in medicine, graduated from Cornell, trained in New York, came to the NIH as a clinical investigator and became very active in the immunology of then the exploding arena of HIV disease. And Tony has gone on to become really one of the international most highly accomplished people in academic medicine. He has received recognitions which would keep us here for the rest of the hour if I were to itemize the presidential awards, the award National Science Award, something like 30 honorary degrees, et cetera. And so we're really most grateful that, given all of his enormous responsibilities here, around the world, the White House, et cetera, that he's always been very supportive of the concept of this Demystifying Medicine program. And so Tony is going to speak first. And afterwards, we'll have time for some questions. Please keep them kind of brief because he may have to leave. And we certainly want to leave adequate time for our second speaker, Jeff Taubenberger, who is received his MD PhD degree at the University of Virginia and is a molecular pathologist, one of those beginning when pathology began to shift from strictly morphology into the linkage to more basic science. He studied, well, he was trained in pathology at the NIH, and then for quite a few years was across the street, well, it wasn't right then, at the Armed Forces Institute of Pathology, where he really introduced molecular pathology. And he's certainly best known for his incredibly dramatic sequencing of the pandemic influenza virus from the great pandemic of 1918. That's a story that I would urge you to go to the website and read about because it's incredibly dramatic as to how it all happened, and I will not take the time to relate that to you. Jeff returned across the street here to the NIH, where he's continued work and his major interest, which is in influenza virus, from the clinical standpoint, confronting the question of, are we going to have another pandemic? What is a pandemic? What accounts for the great variation in the virus? And today he's going to emphasize the common theme, which is resistance. So I will stop. And Tony, thank you very much.
Thank you very much, Wynn. It's a real pleasure to be here again this year to talk about some topics of considerable interest in medicine. This year, Wynn asked me to talk about antimicrobial resistance, and I'm very happy to do that because right now we are really facing an extraordinary challenge, as you see on the first slide here. I call it the perpetual challenge, and I'm going to try to develop during my talk with you the theme of how this is something that is really enduring, that just is not going to go away, but we're really facing somewhat of a crisis now in this country and globally in the arena of antimicrobial resistance, particularly within the arena of bacteria. And that's the reason why we chose the title, Will We Lose the Race or Change the Game? Because there really is a race against microbes that has been going on for a considerable period of time. So I'm going to break the talk down into multiple small components. They're identified on this slide. So why don't we start off with the first, which I always like to do, is define what you're talking about. And the definition of antimicrobial resistance that we get from a number of venues, but particularly the CDC, is that the resistance to a microbe is the result of their changing their ways that reduce or eliminate the effectiveness of drugs, chemicals, or other agents to cure or prevent them. Now, you can get antimicrobial resistance to any of a number of microbes, viruses, fungi, parasites, bacteria. You know that Jeff is going to talk in a bit about influenza, and I'm going to confine my remarks because of the urgency of the particular problem. We could talk a lot about malaria resistance. We could talk about resistance of fungi, but we're going to concentrate on the bacteria exclusive of Mycobacterium tuberculosis, because there are enough information in that really to occupy even more than the time that I have. So let's start off. What is the scope of the problem? We know what the problem is. We know the definition. What is the scope? Well, it's very interesting that, in 1928, Fleming discovered penicillin, and as we all know, that was a very historic time because the era of antibiotics began. But in fact, at the very moment, in fact, I'm going to show you in a minute, even before the antibiotic era began, there was antibiotic resistance, but there really wasn't any antibiotics at the time, and I'll explain to you what I mean by that somewhat paradox. In fact, Fleming himself, when he received the Nobel Prize in 1945, and as I'm sure the history buffs among you know the important role that penicillin played in World War II when it was first used in our troops. But with considerable insight, Fleming made the statement in his Nobel lecture that the time may come when penicillin can be bought by anyone in the shops. Then there's the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug might make them resistant. A spectacular insight for somebody to talk about that long before any problem of antimicrobial resistance came about. And in fact, he was quite correct, because if you look, these are actual signs from stores here in the United States, free antibiotics with something else that you buy. It's really quite extraordinary. And in fact, they're not free, but they're certainly on sale in other countries, particularly in European countries and in South America. So in the United States, antibiotic resistance is a significant problem that is getting worse. It results in lost lives, 2 million drug-resistant infections each year in the United States, with 23,000 deaths per year. The annual costs are really spectacular, about $20 billion in excess healthcare expenditures that we usually see in hospitalizations that are prolonged. I've had the unfortunate experience as a physician who takes care of patients to be making rounds day after day on individuals who have resistant microbes. And if you look at lost productivity, it's even more than that, 35 billion. Now, if you look at it, it is also an increasing global health problem. And the numbers of these are really astounding. In South Africa, more than 70% of the Klebsiella pneumonia that carry a beta-lactamase enzyme, which in fact, as you know, is the enzyme that just completely neutralizes the beta-lactam of the antibiotic. In India, E. coli in urine cultures in pregnant women showed an astounding 59% Bactrim resistance. Now, Bactrim is a very cheap drug. It's a very good drug for urinary tract infections, and this becomes a real problem when you have more than a 50% resistance. And in lower income countries, more than 50% of the Staph aureus cultures in an intensive care unit are methicillin resistant. So this is not just a problem that we're facing, it's around the world. Now, not only around the world, right here on campus, and this is a slide, it says, antimicrobial resistance hits close to home. I'm sure many in this room have read about, over the past couple of years, the problem that we had in the clinical center with a carbapenem-resistant Klebsiella pneumonia that actually spread from point source from a patient who was transferred unwittingly, knowing that they had a resistant microbe, into our wards. And despite extraordinary attempts to prevent the spread by good hospital practice, there was still over 17 cases, 6 of whom died. This was something that was really very serious, and it is not peculiar to the NIH hospital. It's going on all over, except people are not recognizing. We just happen to have the tools to do the deep sequencing, to do the kind of tracing. This is probably going on in, I wouldn't say in every hospital, but in most hospitals. So if you look at the timetable and just take as an example Staph aureus, this is really what I mean when I say that antibiotic resistance, people talk about always on the heels of the introduction of an antibiotic, but in fact, because of the mechanisms of resistance, namely mutations, stochastic mutations that might lead to resistance, doesn't happen very often because there's not a lot of pressure, that if you look at penicillin and Staph aureus and you get isolates before penicillin was actually used, just by going back and isolating bacteria from specimens, there was some penicillin resistance even before penicillin was used. It's only the use of penicillin that amplifies the penicillin resistance. And then this is a story again, for those of you who are in medicine, I'm sure Wynn remembers this. When I was in medical school and a house officer, we were just starting to see the beginning of methicillin-resistant Staph aureus. Then when I got to the NIH, it became methicillin resistance, and then we were using vancomycin, and then we now have other drugs like linezolide and others. And we'll get back to this in a moment. Now, a lot of scholars have been impressed by the whole issue of antibiotic resistance. And Paul Ehrlich, the Nobel Prize-winning physician scientist in Germany, who, as you know, developed the first syphilis treatment and diphtheria antitoxin, made the statement that drug resistance follows the drug like a faithful shadow. And that's a bit melodramatic, but in fact, that is what is going on. So let me go through some of the issues that are associated with this. This slide makes a statement that's quite true. We talk about the pipeline race. The pipeline race is as antibiotics become, as microbes become resistant to antibiotics, do you have other antibiotics to come in and replace them? And it's kind of a pipeline race, more resistance, more drugs. The only trouble is that we're losing that pipeline race because the discovery and the development of new antibiotics has actually decreased. And if you look at brackets of years going from 1983-87 to the present time, the approval by the FDA in this country of new antibiotics has dramatically diminished at exactly the same time as the number of antibiotic-resistant microbes has actually increased. So you have a double jeopardy of two lines crossing, and that's what I mean when we say we're losing the race. So how does this happen? How does it emerge? Well, antibiotic resistance is ancient. And if you look at, and you're going to hear a little bit probably about some permafrost issues, if you look at samples that are tens of thousands of years ago, and you isolate bacteria and take a look at the sequencing, they have resistance genes related to penicillin, tetracycline, and vancomycin. And the reason is that microbes mutate. I know I'm telling this to a lot of people in this room who understand that, but let me just put it into perspective of what I'm saying. Microbes that replicate, particularly those that replicate a lot, tend to mutate. Many of the mutations don't mean anything, but just by chance alone, you're going to get mutations of a microbe that's resistant to an antibiotic. If you then treat, you select, and there are some situations where fitness versus a particular antibiotic is conferred by a mutation, and if you treat with an antibiotic, and particularly if you don't treat adequately for the right duration or the right dose, you wind up selecting for antimicrobial resistance. So it happens anyway, you just make it much, much more amplified when you inappropriately treat, and we'll get back to that in a moment. The mechanisms involved, again, are well described, one of the most important of which is the plasmid base, where if you look at a resistant bacterium and the plasmid that contains the resistant gene, and you have a bacterium next to it that's actually sensitive, you have transfer by conjugation bridges of the plasmid, and this has played a very significant role in the NIAID Klebsiella pneumonia outbreak, where you have now the transfer of the resistance gene. Now, the targets for antibiotics, you all well know these are textbooks: cell wall, like vancomycin and the beta-lactams, DNA and RNA with the fluoroquinolones, protein synthesis with the macrolides, linazolide, cell membranes, daptomycin, and folate synthesis, for example, by the trimethoprim sulfonamides. Those are the targets. If you look at the mechanisms of resistance, some of them are now very well described. You can block the entry of the antibiotics, such as with penicillin. You have beta-lactamase. You have enzymes that inactivate the drug. You have efflux of the antibiotic. It gets in and then it effluxes right out of the cell. Or you can have an alteration of the target, as we have when we have competition for vancomycin resistance. So why does it emerge? We know what the mechanisms of emergence. So how is it that we have a big problem right now? What are we doing to make this problem worse? Well, when you look at it, first of all, the overwhelming issue from a positive contribution to the emergence of resistance is the inappropriate use of antibiotics. And that's almost a sociological, medical, litigation issue. And that is, physicians often are subliminally coerced, as it were, by families to give someone an antibiotic. Let me give you some examples. 73% of adults presenting with acute bronchitis receive an antibiotic. And if you look at bronchitis, it's usually postnasal drip and people start coughing. You go and you think you have a sinusitis. 60% of adults presenting with a sore throat receive an antibiotic, and only 10% need them. Now, one of the things that we're going to get to in a minute is the importance of diagnostics, because the one thing you don't want to miss, and we have very easy tests for it, is a strep throat in someone, because that could have some significant consequences. And when someone comes in for a sore throat, sometimes, and particularly sinusitis, you inappropriately get treated. And these are just some of the numbers that we know from a recent article. Now, the other one that's really attracted the attention, you may have heard of the recent FDA trying to work with the pharmaceutical companies and the Department of Agriculture about the use of antibiotics in animals, veterinary use. This is amazing. Most people don't appreciate this. About 75% of all the antibiotics sold in the United States are used in the veterinary field in animals. Not necessarily to treat infection, but namely for growth promotion. About half of them are used for growth promotion. We could get into a discussion about growth promotion. Does it really promote growth? Or when you crowd all these animals together and you're essentially prophylacting them, that may be the reason that they're growing, not that you're metabolically promoting growth. We don't know that. And resistance among animals is widespread, and there's a lot of work going on talking about and trying to find out data as to whether or not that's transferred to humans. There are other reasons why resistance spreads, and those are things that sometimes you don't have good control over, particularly in developing nations, where laboratory capacity is poor, namely to see if you're dealing with a resistant strain. Health workers are often scarce. Detection is limited because of poor surveillance, because of resource limitation. Informal antibiotic sales are pervasive. People come around just selling any antibiotics. and there's counterfeit and expired drugs. And I wouldn't underestimate the importance of that, because that gets to Fleming's issue of underusing or not using adequate amounts. There are other factors involved. The overuse of broad-spectrum antibiotics. Somebody comes in, we don't know what you have, let's just blanket everything, which is a bad idea unless you absolutely have to do that. Urbanization and globalization facilitates population spread of resistant bacteria. Institution-based care, you go from daycare to nursing homes, then you have the individual spread. And we've seen examples of all of these with individual microbes. So where does it emerge? Well, hospitals are the big players in the emergence of antimicrobial resistance. So, for example, if you look at the cases of Clostridium difficile in acute care hospitals, it has really gone up over the last 10 years from about 130+ thousand to over 346,000. That's in the acute care hospitals. We're also seeing it a lot now in nursing facilities and long-term care hospitals. Now, the difference that gets a little bit scary is that it's bad enough when you have someone in a hospital who's at risk for getting a resistant microbe. But what happened some years ago, a couple of decades ago, was the transfer from things being purely hospital-acquired infections that are resistant to community-acquired infections. And that's exactly what happened with Staphylococcus aureus. It was almost exclusively something that you would get in a hospital. And then when there was close skin contact, such as in locker rooms and wrestlers, it became clear that there were outbreaks in sports. The first reports were with wrestlers, and then football teams. The famous episode of the Dallas Cowboys years ago, who before a Super Bowl had a bunch of staff and they were treating them all with anti-staphylococcal. And then there's also, interesting, in the environment, in India, resistant bacteria were recovered in puddles and even in drinking water, but who knows if the drinking water was contaminated anyway, but it was there. So that's the issue of a spread. Once something becomes community acquired, then you really have a serious problem, because then you have someone who walks into an office with an infection, and most of the primary care physicians are not thinking about a drug-resistant microbe. Whereas in the hospital, the first thing the house staff or the attending thinks about is, are we dealing with a resistant microbe? And that's what happens. So what about the spread of it? Let's take a look at the KPC, which stands for Klebsiella pneumoniae carbapenemase resistant. In 2001, this was the only state that had it. In 2011, it's really a spread essentially throughout the United States. And this is a combination of real spread and realization of the spread. Because remember, the person who came from another hospital to our clinical center, we didn't know that that person had a resistant microbe. So that never really went reported from that place. So you would have never known that it was in that hospital. And then also the spread abroad. And this is for the New Delhi strain that, as you know, came to the United States, back then to Europe, and then came from the Far East back to the southwestern part of the United States. Now, the CDC has indicated appropriately that there are a number of high priority pathogens. So what I'd like to do is to just spend a couple of minutes just giving you some examples of what I've been talking about. So there are two major groups, one that are called urgent threats, and I've mentioned some of these, not all of them, the carbapenem-resistant Enterobacteriaceae, the CRE that you may have seen the abbreviations of that, Clostridium difficile that I mentioned in acute care hospitals and in nursing homes, and then the good old Neisseria gonorrhea. Those are urgent threats. Serious and concerning threats are Staph aureus. In fact, because of the attention that has been paid to methicillin-resistant and vancomycin intermediate and vancomycin-resistant strains, has actually led to a decrease in Staph aureus that are resistant. And that actually is an interesting issue, because it shows that when you pay attention to something and identify it, it actually can decrease. But let's go through a few of these, and I'll just give you a quick feel for them. So take the carbapenem-resistant Enterobacteriaceae. There are gut flora that are generally part of the normal gut flora, not an unusual situation when you're dealing with microbes that can then break out and cause infection. Carbapenem is a broad spectrum but very potent antibiotic. The clinical manifestations are severe GI, GU, pulmonary, as well as gram-negative sepsis. Now, the epidemiology, it was first reported, as I mentioned, in 2001. It's now seen in 44 states. There were 9,000 infections per year now, and the NIH outbreak, as I mentioned, right here on campus in our clinical center, was caused by one of these organisms. The resistance mechanism, as I mentioned very early, is plasmid-mediated for KPC and the New Delhi metallobeta-lactamase that people refer to in the articles as NDM1. They both break up the carbapenems. Now, the tools to combat this are some really simple, low-tech things. We did a lot of high-tech sequencing to do the tracing here in our hospital, but things like surveillance, hospital control, typical simple things like hygiene practices, patient cohorting, active contact tracing, and then treatment. And unfortunately, when you're dealing with such a resistant microbe, you have to resort to older antibiotics that have considerable toxicity. So this CRE is sensitive to colistin, but for those of you who have ever treated patients with colistin, it's something you really got to be careful of because of the nephrotoxicity associated. When I was a house officer, that was the primary drug we used to use for Pseudomonas sepsis, and we wound up saving them from their Pseudomonas sepsis and putting them into renal failure half the time, but with a deadly disease. Now, Clostridium difficile, again, a commensal organism in the gut, a spore-forming organism. The clinical manifestations, they are severe antibiotic-associated diarrhea, pseudomembranous colitis, or sepsis. Now, Klebsiella is something that is foremost on the mind of hospitalists who are treating individuals with antibiotics, because that's what you get when you are on antibiotics for a longer period of time. It's not an uncommon finding that then has to be treated, what we'll get into in a moment, by oral antibiotics like vancomycin. The epidemiology is significant and severe. There are about 250,000 infections in the United States per year and about 14,000 deaths. The deaths have increased dramatically over the 7 years from 2000 to 2007, 400%. Elderly are particularly vulnerable. They suffer from half the infections, but 90% of the mortalities. There have been some really serious, tragic situations in nursing and extended care homes with elderly individuals who weren't really underlying sick, except that they were somewhat infirm elderly individuals where they actually got infected with an antibiotic-resistant microbe and died. The resistant mechanisms are numerous, including plasmid and chromosomal, and there's the more virulent quinolone-resistant strain that is on the rise, and that's the discussion there in that paper. So the current treatments, as I mentioned, metronidazole or oral vancomycin for a simple disease, which is bacteriostatic. There's been a new approval of a drug, fidaxomicin, which is bactericidal. People have used monoclonal antibodies when things really get serious on the really extreme situations that some physicians and surgeons had to resort to colectomy. And then there's an interesting approach called fecal transplants, which we'll get back to in a moment. Again, disease control is a minimization, where appropriate, of antibiotics, because the more antibiotics you give, the more you select for Clostridium difficile. And again, surveillance and proper vigilance and hand washing, wipes and gels don't kill the spores. The amount of effort that's put into hospital control now, particularly because of the sensitivity across the street in the clinical center is really somewhat stunning. I make rounds over there with my colleague Hillary, and we have somebody standing there watching to make sure we do 2 squirts. 1 squirt's not enough, 2 squirts, wash your hands, put on the gown, et cetera. And you lose accreditation if you don't do that. So they're taking this really quite seriously. Okay, fecal transplants usually performed via a nasogastric tube or an enema. I mean, the idea about a fecal transplant immediately says, oh my God, turns people off. But it actually, when you have a pill form, it actually works. And that really is an interesting backdoor way of looking at the human microbiome, how the environment of the gut is really an incredibly dynamic equilibrium of different types of organisms. And when you put in organisms that are, somewhat ludicrous, but it's not, a fecal transplant, you actually wind up having a very high cure rate for some of these diseases. So gonorrhea, sexually transmitted gram-negative diplococci. When you work in an inner-city clinic like I have had both in New York City and in Washington, D.C., back when everything was sensitive to penicillin, there was nothing better, I wouldn't say better, than having somebody come in with acute gonorrhea. It was like one shot, they come back 2 days later, they're all better with penicillin. Well, it isn't the case right now because we have a lot of serious resistance with gonorrhea. The symptoms of gonorrhea, quite symptomatic, very serious, purulent, painful urethritis. For women, it's a serious disease. You can get serious pelvic inflammatory disease that can lead, in some cases, to sterility. Disseminated infection can be very serious. You can have gonococcal arthritis. You can have gonococcal other tissue disease. You could have conjunctivitis in babies born to mothers who have undetected gonorrhea in the vaginal tract when the baby comes through the vaginal vault. You can wind up, if it's unrecognized, getting neonatal blindness. So it's not a trivial disease. People joke about it, I got the clap, as they used to say back in the military time. Well, it can be a serious disease. It becomes even more serious when you have trouble with resistance. And the epidemiology, if you look at it, globally there are 60 million cases per year. In the United States, there were 820,000 cases per year. 30% now are antibiotic resistant. So this is an interesting chart. If you look at the percent resistance, penicillin, like from 1987, is just a lot of resistance to penicillin. Like tetracycline, you would never use tetracycline. Fluoroquinolone was good for a while, and then we had the emergence of fluoroquinolone, the ciprofloxacin, and those types of drugs. And now, if you look, you have reduced cefixime susceptibility. So the resistant mechanisms are, the penicillin is chromosomal, changes in the binding protein. The cephalosporins is chromosomal. So this is one that's interesting. The treatment now is really totally different than it was decades ago. It's ceftriaxone plus azithromycin times 1. It's the advantage of an in-office treatment. I'm going to get to in a second the new treatments that are being investigated, but again, the control mechanisms are disease surveillance and contact tracing and treatment of perhaps an unsuspecting asymptomatic partner. The NIAID and the CDC had a joint clinical trial that was just announced last summer where the licensed drug combinations of injectable gentamicin and oral azithromycin or oral gambafloxacin and oral azithromycin turned out to be almost 100% effective. This is not the recommended for gonorrhea right now. This is to sort of have in your back pocket because we're starting to see the emergence of some resistance that isn't yet to the point where you would say you want to go to this regimen, but we're trying to stay ahead of the game to have a regimen that's highly effective just in case we have that burst of resistance to the antibiotics that we're currently using. Now, Staph aureus, the one that has really put the spotlight on antibiotic resistant, it rapidly acquires resistance to antibiotic, and it could be anything from as localized as a skin infection to total sepsis. And the key resistant organisms include MRSA, which everybody knows what MRSA is, which stands for methicillin-resistant Staph aureus. There's intermediate resistance to vancomycin, which is referred to as VISA or VISA. And then there's the vancomycin-resistant Staph aureus, which is rare but scary because vancomycin is a great drug for methicillin resistance. Then you go to the next one, you have linezolid, which is not used very often, but that's at least one that we tend to use. The epidemiology, as I showed you, it's common. There are 80,000 severe infections in the United States with 11,000 deaths, but as you can see, the rates are starting to decline. VISA is rare, as I mentioned, less than 1% prevalence among the isolates, as well as vancomycin resistant being rare. The mechanisms are given here, the ones that I mentioned, from chromosomal to plasmid mediated. So the treatment, I've already alluded to them. For methicillin resistant, it's vancomycin. For the intermediate and resistant vancomycin, it's linezolid is a good option, which I use, but ceftaroline is also used. Control measures, again, these are the things that have made the curve go down. The campaign to end hospital-associated infections, which is really very much now on everybody's front burner. I met this morning with Francis Collins and Larry Tabak about the White House, becoming extremely interested in addressing the problem of antimicrobial resistance because it's like a part of a global disease surveillance issue. So you're going to be reading about that probably in the newspapers over the next month or so, because once it gets to the attention of the president, something usually happens, probably with no new money, but it'll happen. We'll do it. Okay, so what are some of the potential solutions? Bolster surveillance. I mean, if you look at the tools we already have, even without new antibiotics, there's a lot that you can do to get your arms around antimicrobial resistance. We need pipeline of new drugs, but bolster surveillance. Know that you're dealing with a resistant microbe. Avoid what happened when the person with the carbapenem-resistant Enterobacteriaceae came into our hospital and we were completely unsuspecting that we were getting somebody with that infection. The other is infection control. Now, infection control in the hospital is a serious discipline with hospital epidemiologists devoted just to that problem. That was unheard of when I was in training and when I was doing hospital work. And then control the inappropriate use, which is really difficult because this is a behavioral, societal litigation issue that is not easy to attack, namely the inappropriate use. So also educating the public. Now, education, as those of us who've been involved in healthcare for a long time, education doesn't necessarily equate with behavioral change. You could educate somebody to do something and they won't change the behavior. So even though there's a lot going on, campaigns that the CDC is putting a lot of resources in about getting people not to inappropriately prescribe antibiotics for things like sniffles and sneezes and upper respiratory infections. The overwhelming majority of which is a virus that doesn't have a secondary bacterial component. You know, the FDA has recently, just this past month in December, acted in a very circumspect way of not trying to be doing things that are not going to be well received by the industry, to really have very strong encouragement on the part of both the livestock industry and the antibiotic pharmaceutical industry to curtail the use of antibiotics in the veterinary industry, to put veterinary oversight over it so that antibiotics are no longer going to be sold over the counter, animal antibiotics, to use it in an anti-infective use only, as opposed to trying to use it in a way to promote growth. And that's something that I think that we have a very lightweight science there about the relationship between crowding and prevention of infection versus the real growth promoting. And the U.S. Department of Agriculture really has a lot of work to do in that, and the CDC and the FDA, and to some extent, we at NIH are going to be collaborating with them. So very quickly, what about the role of biomedical research in addressing antibiotic resistance? In 2008, we put out our research agenda, which looked at the three major components, what we can do in basic research, such as gene sequencing, translational research, and clinical research. The importance of approved diagnostics, that's the role we play. Getting state-of-the-art point of care, it will save lives. Tests usually take 1 to 5 days to yield susceptibility. We need susceptibility testing that's measured in hours, because you could even make things worse, because if you don't have the susceptibility, then your reflexes, put them on a broad-spectrum antibiotic or put them on multiple antibiotics, but actually makes the problem worse if you knew what you were dealing with right from the beginning. Reduce the side effects, such as drug allergies, C. difficile, cut costs, rapid testing if you get the right diagnostic. Certain studies show you can save over $20,000 per patient from MRSA. We have been putting some money into this, and we're supporting researchers. There is a new test that came out just this past year in September, which is an RT-PCR gene expression signature to distinguish viral from bacterial infections. So it's not going to tell you what bacteria or what virus, but it's going to tell you that you're dealing with a virus and you're not dealing with a bacteria. So that, I think, is going to be really very important. And I think that's going to really limit the inappropriate use. Genome sequencing centers, right now, by deep sequencing, we have the capability, when you sequence multiple strains, to really pinpoint what the mechanism is and trace whether or not you're dealing with a point source that is transmitting it to someone else. And that's what we did with the clinical centers. So we now have the sequences for more than 800 bacterial strains. It's in GenBank. It's open access to anybody who wants to look at the sequence. And we have about 170 Staph aureus strains that we're going to sequence. The known antibiotic bacteria sequences are mined for new antimicrobial genes. And this is just a schematic showing all of the issues that you can address when you get whole genomic sequence, not only to the biosynthetic pathways, but the drug-resistant mechanisms, the immune evasion factors, and even structural proteins that are good for the development of vaccines. And speaking of vaccines, people tend to dissociate the issue of antibiotic treatment with vaccines. But really, one of the best ways to avoid antibiotic resistance is to prevent the infection in the first place. And there are people who have higher degree of susceptibility to Staph aureus, then you want to develop a Staph aureus type vaccine. If you look at Haemophilus influenza type B vaccine, it's essentially eliminated Haemophilus influenza B, which prior to the vaccine was the leading cause of bacterial meningitis, mental retardation, and deafness in children. And now it's a disease that has essentially disappeared from the United States. So with this as the model, we're going to try and will hopefully get a vaccine against Staphylococcus as well as against certain of the gram-negatives, and be vaccinating people who are at high risk for that. So on the last slide, I want to just go right back, to where I started with when we were talking about, losing the race or changing the game. This really is a perpetual challenge, and we thought that a good analogy to that, or a metaphor, would be it's really kind of like a chess game. The bacteria makes a move, you make a move. The bacteria makes a move, you make a move. You can't get up and go to sleep or go away, because it truly is, in medicine, one of the few things that is and will always be a perpetual challenge, just the way Alexander Fleming said in 1945 in his speech for the Nobel Prize. So I'll stop there, and I think I stopped on time.
Please speak very loudly because there are a lot of people who are listening to this and they want to hear the question as well. So here you are. Go ahead. I can just,
So that was terrific, and I just had a question that seems to me to be obvious. With respect to the emergence of drug-resistant infections secondary to inappropriate use, the way that medicine is practiced in the United States fosters this sort of situation, doesn't it? Because patients come in, they're sick, they want to be treated immediately. They want whatever it is that they have to go away within the next 30 seconds. And they often come in and they say, I'm sick, I'd like an antibiotic. And that kind of situation seems to be getting worse in the United States as these emergent care centers keep cropping up. I've noticed quite a lot of them over the past several years cropping up just within this region. And it seems that it's really the client, the patient, that is fostering this. And in order for companies to sustain their load of patients so that they can make a profit, they encourage this by giving the patient whatever he or she wants to treat their illness. So how do we deal with that kind of situation in the United States where healthcare really is a business and the customer seems to always be right, plus the fact that we seem to be focusing increasingly on patient-oriented medicine and give the customer what he or she wants?
Right. Well, as you said, the question is obvious, but the answer is not easy. And it has to do a lot with the education behavior issue that I mentioned. We could educate as to the reason why that's a bad idea. You can go from education and the hope for behavioral modification to something that might relate to regulation. For example, reimbursements about giving antibiotics. What was the reason for the antibiotic? The only trouble with that is that that really starts to encroach upon medical judgment, and that's a very fuzzy line. Like someone comes in and what was the reason why you gave this antibiotic? Did you do a culture? Did you do this? Did you do that? I personally think the only way to really make that have some teeth is if you do have a point of care diagnostic and someone comes in and says they want an antibiotic and you do it and you say the person doesn't have a bacterial infection, so I didn't give them an antibiotic. But to give them an antibiotic without any other reason than empiric, you know, it could be something that you could link to reimbursement or not. I'm saying that and I'm getting chest pain as I'm saying it because I don't think it's going to work, but that's the best I can do.
With regard to the drug pipeline,
Yes.
do you think the solution is putting more funds into research for antibacterials? Why is it that we have so many more antivirals, newer antiretrovirals in the past 15, 20 years than we do antibacterials?
Sure, good point. It's an incentivization of industry that I just spent an hour and a half this morning with Francis Collins and Larry talking about, because we're going to have to go down to the White House and talk about that in the next week or so. And that is really industry, it has, with some exceptions, has very little incentive to, it costs anywhere between $700 million and $1 billion to bring a new drug from a concept to licensure. That's the cost right now of whatever it is. So when you're looking at an antibiotic, you're looking at something that is going to be sparingly used, usually in courses of 7 to 10 days and sometimes 2 weeks, by a minority of people, and you know for absolutely certain that sooner or later there's going to be resistant to that microbe, to that antibiotic, long before the patent expires. So the incentive to do that is very little. Switch over to HIV. You have 35 million people infected. They get on therapy, and they're on therapy for the rest of their lives. So the incentive, even now, where we have great antiretroviral drugs, the companies are still falling all over themselves to make the next generation. because the next generation, less toxicity, longer acting or what have you. It's really an incentive situation. And what we're discussing is, what does the drug company want to incentivize them? We, NIH, can do something. We can de-risk what they do. We can do some of the things in research that brings them to the point where they see the concept looks good. We can do screening, pharmacokinetics, pharmacodynamics. We're doing that essentially for free. But that still doesn't overcome the disincentive that they have. What they really want are things like extension of a patent. So if you could tell Pfizer, we're going to extend your Viagra patent, which is a $7 billion a year industry, for 1 year, would you put in $1 billion to make a new antibiotic? They'd do it in a heartbeat. They would do it in a heartbeat. But there's a lot of reluctance to give them patent extensions.
Hi. I have a question about one of the graphs that was in your presentation, which showed that certain bacteria can lose resistance to a certain antibiotic. How does that happen, and is it ever viable to bring back an old antibiotic that a certain disease has lost resistance to?
Well, I don't know if it said lost resistance, that it said we go back and use antibiotics like colistin, to which resistance had never been developed, but you have a microbe that's resistant to everything we have, and you'd have what's called repurposing of going back and using an old antibiotic for something now, because you haven't used it in so long that it reverts back to wild type. So that's what you mean by losing resistance. So it's wild type for colistin, because the generations of microbes that have been passed on from one person to another, et cetera, wind up being resistant to the drugs in 2010, but no longer resistant to the drugs from 1965 and 1970. That's what we mean by that.
Great talk. With the resurgence of some of the older drugs, do you think there'll be like a return to some of the older treatment options like phage therapy or?
Phage therapy is always on the burner of the kinds of experimental things you want to do. I think that even without going back to old drugs, that's something that's being pursued right now. So that's a very hot area of research.
In reference of the antimicrobial peptides, are they considering to really invest in that research, or is out of the?
No, peptides, again, are difficult from the standpoint of administration and getting concentrations enough, but antimicrobial peptides are an area of research that are being screened. Companies do it. We have some with NCATs now, a little bit of it, not a lot.
Okay, my question was about alternatives to.
Oh, sorry.
Alternatives to antibiotics based on the chemistry.
Yeah.
And my other question is regarding this agricultural use. How do you think it will be welcoming in the Congress? Because I just read in a newspaper, this issue is like a gun control debate in the Congress.
Yeah, good. You should have seen the hearing when they beat me up when I suggested that, in fact, that it was a bad thing. It was lobby-driven. So, yeah, there are alternative approaches, and some of them are, for example, to block the toxins of antibiotics, of microbes whose major mechanism of pathogenesis is a toxin, not necessarily that's the first thing. The other is to not necessarily have to kill every single microbe, but to actually bring down the titer of some of them, where you can get some bacteriostatic that essentially gets wiped out, even if you don't kill every one of them. Vaccines is another alternative. Monoclonal antibodies is another one, particularly antibodies against some of the toxins. And we're working with that. That research started with the biodefense when we were making antibodies against, for example, anthrax toxins. So there are non-antibiotic approaches. I think the most important of which is probably vaccination against the susceptible populations.
What about the Enterobacteriaceae, other than C. difficile and fecal transplants. There have been some reports in the literature of people with drug-resistant E. coli and so forth.
No. The trouble is, since it's plasmid, I mean, you can get a Klebsiella-resistant plasmid transfer to a plain old benign E. coli. So that's really an issue you got to be careful about.
I was referring to the fecal transplant.
I see. Right, exactly. We're worried about fecal transplants. It's sort of like organ transplants that are contaminated with Jakob Creutzfeldt, right?
It could be. Please, speak up loud.
It really is a replacement of flora. I mean, that's why I alluded to the microbiome project. So if you take normal flora, I mean, fecal transplant sounds like a bizarre way to say it. What you're really doing is transplanting of normal intestinal flora to repopulate a flora in a sick person that's dominated by C. difficile or dominated by another microbe that's causing the problem. So it really is the balance of the microbiome. So if you take somebody with a totally normal flora and you put that either with a pill or by an NG tube, you're essentially going to overpopulate it with normal, non-pathogenic, non-resistant microbes. That's the reason for it.
Same dynamic applied to other infections?
Not in, you mean infections that are outside of the GI? No, but that wouldn't do any good there because it's already in the tissue out of the gut. You wouldn't want to do a fecal transplant for someone. Oh yeah, sure. I mean, there's a lot of experimentation. In fact, the whole microbiome project is trying to look at, that dynamic between microbes in the gut. I mean, that's a really hot field right now. Yeah. Yes. Yeah, that's a good question. The question he didn't, was what global approaches. So there's a WHO and international transatlantic consortium now, of which we are a part of, that is looking at how we can get some harmonization of surveillance and exchanging of data and sort of uniform antibiotic practices. Very, very much involved. The UK is playing a pretty good leadership role in that. Totally, yes. Yeah. Absolutely. Yeah. Yeah. No, the question is, if you're going to do a PCR and you have a sophisticated enough process that you can tell if it's a virus or a bacteria, you could also take a look at the virus or the bacteria, and since you know what the resistant genes are, you can identify by PCR if you have the resistant gene. The answer is yes. And in fact, that is done with the point-of-care gene expert machine that you use to diagnose tuberculosis and whether or not it's rifampin resistant. So that's already being done for tuberculosis. There's no reason at all not to do it in the situation I just mentioned to you.
Okay, I think we better move along, and thank you very much.
You're welcome.
That was spectacular. So now we're going to shift to influenza, which is a virus, which has a whole different set of problems associated with it, and Jeff Taubenberger is going to discuss.
Thanks very much. Give you my very first piece of advice, which is never follow Dr. Fauci on the podium. So that's the most important thing that you'll hear from me today. So we're going to focus in on a smaller problem, literally and metaphorically, from the bigger problem of antibiotic resistance, generally to specifically one particular pathogen, which is influenza viruses, which are a major public health problem in both their seasonal influenza and pandemic influenza manifestations. So first, just to introduce you to the bug in question. Influenza viruses are single-stranded RNA viruses, they're sort of mid-sized RNA viruses, and they have a couple of features which are important for understanding how they replicate and why antiviral resistance is important. One of them is the fact that the gene segments of the virus, the RNA segments, are not one piece of RNA, but 8 separate little pieces of RNA that are called segments that each encode one or more open reading frames. They express about 13 different proteins through these 8 genes. And so if 2 different influenza viruses co-infect one host at the same time, you can create viruses that mix and match gene segments from the 2 different viruses and create progeny viruses that have different properties, both genetic and antigenic and physiologic properties. So that question of reassortment is an important question. The second issue is that the polymerase genes of the virus, as in other RNA viruses, the RNA polymerase complex lacks proofreading and is incredibly error-prone. So unlike the rare mutations that you see in DNA, influenza viruses live to mutate and live in a quasi-species pool with very frequent mutations. There are 2 major surface proteins on the surface of influenza viruses, the hemagglutinin, or HA or H, of which has 16 different antigenic variants circulating in birds, several of which have adapted to humans. And neuraminidase has 9 different subtypes in birds, and additional HA and NA subtypes have been identified recently in bats. And these are on different segments, and so different influenza viruses with different combinations of H1 through 16 and N1 through 9 have been seen. The HA and NA have basically opposite properties. The HA has as one of its major roles is to bind sialic acids on the surface of glycoproteins decorating the tips of respiratory epithelial cells in mammals. And the neuraminidase basically has the opposite effect, which is to cleave off, it's a sialidase or a neuraminidase, to cleave off the neuraminic acid or sialic acid off the tip of these glycoproteins during viral budding so that the progeny viruses can be released from the cell. There's a small M2 ion channel protein coded by the matrix gene, which is important in the early stages of viral replication, which we'll talk about, which is a target of the older class of antiviral drugs. And the second class of antiviral drugs that are available to treat influenza viruses are inhibitors of the neuraminidase enzyme, or NA. So influenza viruses are fantastic at responding to Darwinian pressures of different sources, whether that pressure is the pressure to adapt to a new host or to escape from pre-existing immunity, or in the topic of hand today, to escape from antiviral drug treatment. Because they live in this sort of quasi-species pool, so that almost every influenza virus virion that's made has some errors in it compared to its neighbors, you can find mutations at basically every nucleotide in a pool of influenza viruses. They're only 13,000 bases long, so it's easy to acquire mutations with such a high error rate. So one of the first problems facing influenza as a public health problem is the fact that influenza viruses are pathogens of a very large number of warm-blooded animal species, both avian and mammalian. It's thought that wild birds like these ducks and other aquatic waterfowl are the natural reservoir of influenza viruses, where they tend to be GI viruses rather than respiratory viruses. They're shed from the cloacas shown anatomically there. And these viruses can circulate in hundreds of species of wild birds, but also have the ability to cause infections, not just one-off zoonotic infections, but stably adapting to different host species, either domestic poultry like chickens, turkeys, and quail, et cetera, but also various mammalian species, including mammals that are very important to us agriculturally and economically, like horses, pigs, dogs, et cetera. And importantly, these viruses then have the ability to adapt to humans. So new influenza viruses of new strains for which there's little population immunity pop up occasionally in humans, averaging about every 40 years or so, although there's no periodicity to this. And if a strain that is immunologically distinct appears in humans and also has the ability to spread efficiently person to person, you can create a situation that would cause a pandemic. And these pandemics have been occurring for hundreds, if not thousands of years. There have been 4 in the last 100 years for which we have some genetic information. The worst one on record, the 1918 Spanish flu, which resulted in over 600,000 deaths in the United States and up to perhaps 50 million deaths globally, was an H1N1 virus. And then subsequent to that, there have been pandemics in 1957 and 68 with the replacement of the hemagglutinin and neuraminidase genes to H2N2 and then H3N2, and then H1N1 viruses of the 1918 lineage recirculated again starting in 1977. And then in 2009, a new flavor of H1N1 appeared, which was a swine origin virus, a pandemic H1N1 virus a couple of years ago. While there's a lot of concern about pandemic viruses, seasonal influenza viruses continue to be a major problem. And in fact, annual death rates to seasonal influenza viruses can be higher than the mortality impact of pandemic viruses. The 1918 virus is certainly a very severe outbreak, but seasonal flu is a huge problem. And that up in the United States, as many as 49,000 people die in 1 year of flu. It's quite variable, but there have been years where the mortality rate of seasonal flu is, as I said, is higher than the impact of pandemics, with the exception of 1918, which stands out by itself. So influenza is a problem, a multifaceted problem, and trying to prevent and deal with the consequences of these infections are important public health consequences and important agricultural problems as well. So just to look briefly at the amazing ability of influenza viruses to evolve, I just show you a bit of a tree of a hemagglutinin gene of H3 subtype from some human isolates over about a 10-year period. And you can pretty reliably date an influenza virus HA gene sequence from a human isolate very accurately by year. So you can say this is a 2002 virus, and this is a 2001 virus, and a 2000 virus. And this amount of incredible plasticity in the genome and the ability of the virus to not just randomly mutate, but in this case, to acquire mutations that change coding sequences on the surface of the globular head of the hemagglutinin so that pre-existing antibodies are no longer neutralizing, allow the virus to escape, which is why the influenza virus vaccine has to be reformulated every year to keep up with this drift. This chart shows the number of antigenically significant changes that occurred to the H3 hemagglutinin over its 30-year period of circulation, and each one of these reflected a strain change in the vaccine. So just keeping up with influenza evolution and producing vaccines for seasonal flu is a huge problem, much not even taking into account the unexpected emergence of a pandemic vaccine, pandemic virus for which we do not have a vaccine, in which there would be a lag of several months to produce a vaccine. So the best way to treat influenza is to prevent it by vaccination, not antiviral treatment, but there are problems with the vaccines. So not every year's vaccine is a perfect match to the viruses that are circulating. Seasonal viruses, pandemics occur in which there would be a delay of at least 6 or 8 months before vaccines are available. But even if everything is well matched, the vaccine is not completely efficacious, and especially people who are immunocompromised and the elderly may not have such a good response to the vaccine, so that they are not protected. And so the future goal is to make better vaccines, more broadly reactive or universal vaccines that wouldn't require reformulation every year. But absent vaccination, or in people for whom vaccine is either unavailable or has not been effective, the best strategy to treat severe influenza is the use of antiviral drugs. Now, typical cases of influenza are self-limited, and for most people who get infected with influenza, you may be sick as a dog for a week and feel really, really terrible, but you're going to get better. And you don't need antiviral treatment or antibiotic treatment. But people who have underlying comorbidities, whether heart disease, pulmonary disease, immunosuppression, cancer, other diabetes, other comorbidities can get more severe infections that result in severe and life-threatening influenza infections, often followed by severe and life-threatening secondary bacterial pneumonias. So in the future, we certainly need better anti-influenza drugs, and I will show you where we are and where I think we need to go. So I think that there are really sort of a tripartite view of the factors that result in severe and fatal influenza infection. The first one is that viral factors, certain viruses are just inherently more pathogenic than others. The 1918 virus was just a very pathogenic virus. It was pathogenic in humans. It's pathogenic without adaptation in a number of experimental animal model systems. There are host factors, including particularly the inflammatory response to severe influenza infections, in which the inflammatory response itself becomes part of the problem, and you get an immunopathogenesis in which you're actually damaging respiratory epithelial cells in the lung because of the inflammatory response. And then secondary bacterial pneumonias come in as the sort of final straw that often leads to a fatal infection. And so intervening in all three of these spots is probably important in treating influenza under different conditions. So most of the effort over the past decades has been to develop drugs against the virus itself to block viral replication. So we'll start there. There are two classes of antiviral influenza drugs that are approved, and each of them have two approved drugs each in the United States. They're the older adamantanes from the 1960s and 70s, which are M2 ion channel blockers. And then there are the newer drugs, the neuraminidase inhibitors of the 90s, oral oseltamivir and the inhaled zanamivir. And just to cut to the chase, the vast majority of recent H3N2 virus circulating are resistant to the adamantanes, and seasonal H1N1 viruses from about 2007, before the pandemic, became nearly 100% resistant to oseltamivir. The 2009 pandemic virus came into human circulation from after reassortment in swine, and those swine viruses that were the ancestors of the 2009 virus were already amantadine resistant, but they were sensitive to oseltamivir. So briefly, influenza viruses, as I said, the hemagglutinin binds to sialic acids on the surface of respiratory epithelial cells. The virus is taken up into the cell, into the endosome, where the HA has its second function, which is to fuse with the membrane, to spill out, in a sense, the guts of the virus, the genes of the virus, the RNPs, which have to dissociate with a necessity of lowering the pH inside the virion, and that's where the M2 ion channel comes into play. The RNP then goes into the nucleus. Replication occurs in the nucleus and then is packaged as budding virus, and the neuraminidase cleaves the budding viruses off the surface sialic acids on the way out. So the two drugs that are approved are relatively early stage, the M2 at early stage before the viral genes are copied, and the neuraminidase actually inhibits the very last stage of viral replication, in a sense, after most of the damage has been done, which is the release of budding viral progeny from the surface of the cell. So here is a virus being internalized in the endosome, and the M2 proton pump pumps protons from the endosome into the surface of the virion, which helps dissociate the RNPs from the M1 core, allowing the RNPs to translocate to the nucleus, where they undergo replication. And so the adamantane drugs, these ion channel blockers, literally kind of plug up this pore and block this proton pump, which, if it works, then stops viral replication at this early stage. The drugs, the class of adamantanes, amantadine and romantadine, have this very interesting sort of cage-like cubicle structure, and they sit in here in this pore. Unfortunately, something that's been known for decades is that resistance to these drugs develops very quickly. If you look at patients who are treated with adamantanes, very quickly they develop resistance, and so it limits the utility of these drugs. There are a number of particular mutations which develop, but one of the more common ones is a mutation at amino acid 31 of the M2, which acquires a change that allows it to remain functional but be resistant to both amantadine and romantadine. So in work done by my colleagues, Martha Nelson at the Fogarty, as well as Eddie Holmes at Penn State, and their colleagues, they were able to do some phylogenetic analyses of H3N2 viruses in the early part of this past decade to show that in this study that amantadine-resistant mutations in the M2 gene occurred at least 11 times independently. Most of them were just short-lived, they didn't spread, but that in about 2003, a lineage occurred that developed amantadine resistance, probably following treatment. But then the virus containing that matrix segment reassorted with an HA that had an antigenically variant hemagglutinin, and that hemagglutinin was selected for because there was immunologic drift pressure to escape, and it carried that matrix along with it that had amantadine resistance. And so what happened was kind of a selective sweep in which most H3N2 viruses then after 2004 and 5 were resistant to adamantanes, but almost none of those patients were treated with the drug. So I would call this kind of a hitchhiker mutation. So the drug pressure caused a mutation to occur in a particular virus. That virus itself, the drug pressure was not the pressure that's selected for that virus being amplified in the population, but its relationship through reassortment with an antigenically novel hemagglutinin allowed that amantadine resistance to spread globally, so that the majority of H3N2 viruses in 2007 and thereafter were adamantane resistant. So the next class of, the newer class of influenza antivirals target the neuraminidase, which is the second major surface glycoprotein on the virus. HA is a trimer and plays a role in binding, as I said, and fusion. And the NA plays basically the opposite role, which is release of the virus from the budding viruses from the infected cell. And it is expressed as a tetramer, kind of like a mushroom-shaped structure. And this is looking down on the crystal structure of the homotetramer. Each one contains an enzymatic active site, the sialidase active site. And the neuraminidase inhibitors were designed to block this NA function. And so rather than being able to release progeny virus, the neuraminidase inhibitor, when present, can act as a competitive inhibitor of the neuraminidase enzyme, prohibiting release and limiting the spread of virus. This is a competitive inhibitor. Here's the sialic acid sugar on the tip of the glycoproteins, which is cleaved off by the neuraminidase. And you can see that the orally available oseltamivir and the inhaled zanamivir drugs are structural mimetics of sialic acid and bind into this pocket. And because they were binding into the enzyme active site as competitive inhibitors, and they were designed as sort of rational drug design from the known structure and function of the enzyme, the rationale was that mutations would occur, but that these mutations would be attenuating, since you'd be attenuating that enzymatic activity necessary for viral function. And that was certainly the case, and that when these drugs were tested both in the laboratory and then in clinical testing, that was the result that was observed. But an interesting thing happened is that seasonal H1N1 viruses, which are ultimately derived from the 1918 flu, in about 2005 and 6, started to circulate that had acquired oseltamivir resistance. And these viruses were circulating and didn't appear to be attenuated. And they had acquired a particular mutation in the enzyme active site, histidine to a tyrosine mutation, and that became fixed. And these viruses were not attenuated. And what happened was is something very similar to the amantadine story. In this case, work done by Jesse Bloom and David Baltimore and their colleagues showed a similar feature, which was that mutations occurred in the N1 neuraminidase prior to the emergence of oseltamivir resistance that made the NA more stable, such that when the H275Y occurred because of drug pressure, it was no longer attenuating in the virus. So once that happened, and those changes probably occurred again by antigenic drift of the neuraminidase. So while this mutation must have occurred or likely occurred in the presence of oseltamivir use, its selection and then purifying selection in the population so that nearly 100% of viruses thereafter were oseltamivir resistant were not due to continued use of oseltamivir in the population, but to other features that were selected for. So again, the antiviral mutations sort of by hitchhiker. So unfortunately, the situation before 2009, which was that the two circulating influenza A strains, H1N1s, were resistant to oseltamivirs and H3N2 were resistant to adamantanes, certainly limits our armamentarium for influenza virus antivirals. So I'm just going to show you some patient-related data from our studies here at the NIH Clinical Center to show you the impact of antivirals on direct patient care. So Matt Memley in my group has been running clinical influenza research studies in the lab in the last 7 or 8 years. And one of those studies is a natural history study in which we recruit patients who are infected with influenza. And then once we recruit them into our study, they're treated by standard of care, but then we do a daily nasal wash on them, and they do sequence analysis and deep sequencing and immunologic studies and follow up what's happening to the virus as they're infected, rather than just getting one initial diagnostic specimen. And many of the patients treated here at the NIH are immunocompromised with cancer or other immunodeficiencies. And many of the patients we've seen with immunodeficiencies have very extensive influenza infections that last much longer than the 5 to 7 days that an immunocompetent person would have. Sometimes for weeks or even months they can shed influenza viruses. And many of these patients are treated with antivirals for a very long time. And this sets up a situation in which the patient can't clear their influenza viral infection because their immune response is inadequate to clear the viral infection. And in a sense, the only selection pressure being applied to this virus is antiviral resistance. And we've seen the rapid development of antiviral resistance of both H1 and H3 strains in immunocompromised patients. So first example, a patient who was being treated here at the clinical center a few years ago with lymphoma, who had a stem cell transplant and was severely immunocompromised, developed influenza, was in the hospital, was being treated for other medical problems, but then was being treated for his influenza and received Tamiflu by a standard dose, but longer than 5 days. He was able to eventually clear his influenza infection, but because we were, pardon me, because we were doing daily nasal wash, we noticed an interesting thing, that when we sequenced the genomes of the virus from every day, that this patient on day 5 or 6 developed an in-frame mutation of 4 amino acids, a 12 nucleotide deletion in the middle of neuraminidase, very near the active site. And this mutation had not been described before in N2 subtype viruses, and we thought this was quite interesting. And when we evaluated this in the lab, we found that the virus with the mutation acquired a huge amount of resistance to oseltamivir, that it took more than 2,000 times the same amount of oseltamivir to inhibit the virus in vitro than the wild-type virus. It also had a significant reduction of efficacy of zanamivir, even though the patient didn't see zanamivir. And since it was an H3 virus, it also was already resistant to amantadine. So what we had is a virus that was resistant to all 4 available drugs, and what we hoped was that this virus was attenuated. Unfortunately, when you put it into the best model we have of experimental animal models of influenza infection, which are ferrets, we find that the virus replicated identically to the wild-type virus, including in its ability to transmit from one ferret to another, so that there was no difference in the way this virus behaved in the terms of its ability to replicate, in terms to cause disease or transmit. And so what we have is a pan-resistant influenza virus that presumably is completely fit. Luckily for us, we have no evidence that this virus spread and that there was no selective advantage for this virus to spread. That is, if another person was infected with this virus and had a self-limited infection and didn't require antivirals, there would be no reason for this particular virus to survive, because it didn't have antigenic drift pressure or other things. But this shows you the ability in just a few days for a virus to become resistant to everything we could throw at it. When the 2009 pandemic appeared, we saw a very similar thing. So I show you two patients, both from October 2009, sort of at the height of the pandemic here at the clinical center, both of them also with cancers and immunodeficient. And they both shed virus for a very long time. And they were both treated with antiviral drugs for a very long time. Patient B became very critically ill and was in the critical care unit for a long time. And after it became clear that they were clinically resistant to oseltamivir, a compassionate exemption was granted to treat them with an experimental antiviral neuraminidase inhibitor, peramivir, which is not licensed. The patient was treated with 10 days for that and then treated with inhaled zanamivir once they were extubated. In these two cases, they both developed this neuraminidase mutation at 275, the H2Y mutation, within 1 to 2 weeks, 9 or 14 days after treatment. And they both developed, again, severe evidence of in vitro resistance to these drugs by various assays, hundreds of fold change in their sensitivity to these drugs. This was the first evidence of clinical resistance to peramivir that had been reported in influenza. And using a molecular assay to look at wild type or resistant viruses, we're able to see that at the initial isolates, there was no evidence of, by RT-PCR, in this case TACMAN, of the mutation, that in patient B, by day 9, it was in about equal measure, 50-50 between wild type and mutant virus through day 17. And by day 31, there was only the resistant virus and no evidence of wild type sequence present. Unfortunately, like the case with H3N2, these 2009 pandemic viruses, like their seasonal H1N1 viruses acquiring this NA mutation, were not attenuated in their ability to cause disease, replicate, or transmit between ferrets. And the pathology that they induced was identical. They both induced viral pneumonia as evidenced by this acute bronchiolitis. So it's, I think, quite clear that the world needs more influenza antiviral drugs. Fred Hayden has recently written a very nice review on new drugs that are in various stages of research and investigation in the pipeline. This article is available online. And this very long list of investigational antivirals, looking at all stages of viral replication, from blocking HA binding to target cells to inhibiting all different stages of viral replication, polymerase inhibitors, et cetera, are being investigated in the laboratory. The question is, which, if any, of these drugs could actually make it to market is unclear. There are some drugs that are further along in phase 2 and phase 3 trials. There are different neuraminidase inhibitors for which resistance mutations might be subtly different, but one of them, the peramivir, is the one that when oseltamivir treatment occurred in some of our patients, and then peramivir, they developed clinical resistance to peramivir. So the utility of this drug for patients who have oseltamivir resistance is unclear, at least for H1N1 viruses. There are long-acting neuraminidase inhibitors, and there are other drugs that are being evaluated. And so if you want more information about these new drugs, I think this is a nice review for you to look at. Let me, in the last part of the talk, turn to the other two factors that can result in severe disease with influenza. Let me talk about inflammatory response factors of the host and the possibility of targeting severe infection not by targeting the virus, but by targeting the inflammatory response. The 1918 virus has as one of its features the ability to induce very severe disease in various animal models, mice, ferrets, macaques, without prior adaptation. It was a very severe pandemic in humans. Millions of people died. But one of the features is that that you see in all of these animal species is a profound upregulation of a pro-inflammatory response, including pro-inflammatory genes, ROS genes, cell death genes, et cetera, compared to less pathogenic viruses like seasonal H1N1 viruses. And so one of the factors that we see is a lot of neutrophils, and so John Cash and my group and Rod Levine and NHLBI, we formed a collaboration in which we wanted to look at the possibility of treating severe influenza infection not by targeting the virus, but by targeting a part of the inflammatory response, in this case the ROS response. And so the choice was given to use a saline manganese compound, and particularly EUK207, a eukaryon compound which has potent catalase and superoxide dismutase mimetic activities. And so interestingly, if mice given a lethal infection with the 1918 virus and then either treated with vehicle or treated with this drug, had a marked difference in survival and pathology, with markedly less pathology in the treated animals and much less evidence of ROS damage and much less evidence of apoptosis. And interestingly, it didn't affect viral replication at all. And by deep sequencing, there were no viral mutations seen after 8 days. So this drug is not targeting the virus at all. Viral replication isn't inhibited, but you're treating part of the inflammatory response, but you can save mice with a lethal infection so that they can get past the initial damage to clear their viral infection. Then finally, let me talk about bacterial factors. Of course, antibiotics are used to treat bacteria, and one of the things that Dr. Fauci mentioned was the fact that when people get a viral infection like the influenza, they want antibiotics, which of course they don't need. But there are patients who do need antibiotics. Those patients who develop secondary bacterial pneumonias really do need antibiotic therapy. The key for clinicians is to determine who of the subset of patients needs antibiotic therapy and making an early diagnosis and appropriate intervention before a serious and lethal infection can occur. In 1918, a metadata analysis of over 8,000 autopsies that were published at the time of the pandemic suggests that over 95% of them had secondary bacterial pneumonias at the time of their deaths. And you think, well, this was before antibiotics were used, so that sort of makes sense. Well, secondary bacterial pneumonias continue to be the major reason for serious illness and death in influenza infection even today. And while in 1918, in the autopsies, you can see tons of secondary bacterial infections with common pneumopathogens like pneumococcus, group A strep, and staph, you can see the same infections today in hospitals across the country of people who get an influenza infection who have underlying comorbidities and then develop secondary bacterial pneumonias. In studies of the 2009 pandemic, autopsy studies done in the first couple of months after the emergence of the pandemic in 2009, the majority of patients died with secondary bacterial pneumonias, even though almost all of them were treated with broad-spectrum antibiotics, including MRSA infections. And we had several community-acquired MRSA infections, this particularly tragic case in a 2-year-old child who got the flu and then developed a MRSA pneumonia with abscess formation and necrotizing pneumonia in the lung. Community-acquired MRSA, not in the hospital. So there's been much work done in my group, Dan Chertow, John Cash, and their colleagues are doing a number of experiments plus a number of labs across the world looking at the role of secondary bacterial pneumonias in following viral infections. And while this interaction is quite complicated, basically one of the take-home messages seems to be that influenza viruses, in a sense, kind of clear a path for secondary bacterial infections, which are either going to be acquired locally within a hospital setting or might even be commensals that are being carried in your upper pharynx. You might be carrying staph or MRSA in your nose without disease, with no ability to cause a pneumonia. But once influenza viruses go through and cause enough damage to respiratory epithelial cells in the lung, they can seed these bacterial infections, and you can be set up for serious and even fatal bacterial pneumonias. So in the last couple minutes, let me just bring this together so that influenza viruses kind of live to mutate. Their reason for being, in a sense, is to mutate, to respond to various kinds of pressures. As I said, the pressures to change hosts, to adapt to new hosts, to escape pre-existing immunity, hence the need to reformulate the vaccine all the time, and more recently, the ability to escape antiviral drug pressure. Clearly, the 4 drugs that we have, the 2 classes of drugs we have, are proving inadequate, and we need new drugs. But I'm not sure how close any of these new drugs are for approval, and this is clearly an important issue. The role of drugs that would target the inflammatory response in severe influenza infections like 1918 or possibly like avian influenza virus infections are not yet known, and there's certainly nothing close to clinical trials for drugs like this. And of course, the role of antibiotics is really important. As I said, you don't want to overuse antibiotics, as Dr. Fauci mentioned, but for patients who are at high risk for secondary bacterial pneumonias, people with underlying comorbidities, lung disease, heart disease, immunodeficiency, for those patients, knowing exactly when to intervene with antibiotics and being aware clinically of the importance of applying secondary antibiotic pressure for patients who are at risk of a secondary bacterial pneumonia is extremely important. So I think in the future, we need new classes of antiviral drugs. Hopefully we'll have newer classes of other drugs that can target inflammatory response in severe disease. We need more antibiotics and bacterial vaccines to reduce bacterial secondary pneumonias like the pneumococcal vaccine, for example. But I think that what we really need are better vaccines to stop influenza virus infection in the first place. And what we need are more broadly reactive or so-called universal vaccines that could allow us to be better prepared for both the unexpected drift changes occurring in seasonal flu as well as unexpected pandemics. So I will stop there. This perpetual challenge with flu is something that I think we will always face. And I thank all the people in my group as well as colleagues here at NIH and elsewhere who contributed to the studies I described here. So thank you.
Thank you very much, Jeff. Do we have some questions or comments? Yeah. By the way, are those the patients who were in the clinical center who were shedding virus for 40, 45 days, were they clinically ill during that period of time? So this parallels there.
That's an excellent question, and I should have made that clear. One of the interesting things with the immunocompromised patients is that they often stop having any clinical illness. We've had patients shed influenza virus for over 6 months and not be symptomatic. So I think, again, that the symptoms relate to the inflammatory response, the interferons and others, and so if you're not mounting an immune response, it probably contributes to a lack of symptomatology. So that's actually another issue, is the awareness of the fact that an immunocompromised patient might not be manifesting an influenza-like illness, but actually might be shedding virus, which could spread to someone else.
Right. So what I was getting to is their recommendation then of what people in a family, children, other immunosuppressants.
Well, the only...
What do you do if somebody who has cancer, for example, gets influenza and recovers?
Yeah, so what we try to do is typical kind of respiratory precautions that you would do. But for patients who are hospitalized, that's easier to do, but when they're home, it's more difficult to have respiratory precautions. We can encourage people to wear masks, for example, and wash their hands, but it is a complicated problem. And for these multi-drug resistant viruses that we've seen emerge in these patients, this is our big concern, is that these could then spread in the community.
So who wears the mask? The patient or everybody?
Well, at home, it's the patient. In the hospital is sort of the opposite.
Why does the seasonal flu virus tend to die away when spring and summer come? And similarly, why does the pandemic virus go away at all? Why doesn't it just...
Well, okay, so the pandemic viruses don't go away in the sense that the pandemic viruses become seasonal viruses within a couple of years. So they're pandemic for a year or two, and then they begin to circulate annually in humans they set into this sort of annual circulation. So seasonal viruses are just pandemic viruses that have been circulating in humans for several years. So in 1918, a pandemic occurred, and maybe the pandemic theoretically stopped in 1919. In 1920, H1N1 viruses directly derived from 1918 virus were still circulating, but now we're quote-unquote seasonal viruses. Seasonal viruses, influenza viruses tend to cause disease predominantly in winter months, and it's not clear exactly why that is. There's probably temperature, humidity issues, people crowding dry membranes because of heating, all sorts of factors that probably contribute to that. And of course, we have two winters, right? So that are 2 months apart. So 6 months apart. So the northern hemisphere and the southern hemisphere winters, and flu season is 6 months apart. So South Africa and Australia get their flu season in our summer, and viruses actually just kind of bounce between their winters. So the viruses are circulating, and if you look very carefully, you find influenza viruses circulating here. You see it in our hospital in July. It's just not a big epidemic, but it's not that viruses go away, but they're environmentally, I think they spread better in winter, and so they tend to kind of follow the cold months.
Is it known whether the virus that you sequenced from the 1918 pandemic, did that have any amantadine mutations or Tamiflu mutations?
It did not. It's sensitive experimentally to all 4 drugs. Did not have those mutations.
So what's your explanation as to what the cause of the pandemic, the 50 million people, 5 million who died, what do you think was going on?
Well, I think it's a difficult question. I think that, one, it was a very virulent virus. I think it was an inherently virulent virus, and one of the ways it manifested its virulence was to have the host mount a very strong pro-inflammatory response. And I think that that inflammatory response was a big part of the damage in 1918. And it could be that's unique to a virus like 1918. Now, it could be that some of the bird flu, H5N1 or H7N9 infections are inducing a similar inflammatory response. But I think it's a chicken and egg issue. You wouldn't get the inflammatory response without the virus. The virus is inducing that, and we're trying to work out what those mechanisms are.
Was it a cause of Parkinson's disease?
I do not think so, no.
But was it linked to the young people, though? I thought, right? Was in 1918 the population were young people getting it?
So an interesting feature of the demographics of pandemics versus seasonal flu is that the mortality impact of seasonal flu tends to be in the elderly, with lesser impact of younger people, where in pandemics that age demographic shifts. Because you have a pandemic virus that has novel surface proteins for which there's no population immunity, younger people are at risk too, and so you see a lower shift. This is true in all pandemics. But in the 1918, there was a particular propensity of people between about age 15 to about 35 to have very high case fatality rates to infection, far different than other pandemics. And it's unclear exactly why that is. An older idea that still could be relevant is that patients at this sort of prime of life were able to mount the most robust inflammatory response. And if the inflammatory response was part of the problem, that could be one explanation. But it's still not really certain what all the explanations were for the unusual age-specific mortality.
Yeah, a few years ago, when there was great concern about the possibility of another pandemic, and the newspapers, magazines were all full of it, there was a crash program to store Tamiflu and vaccines. What's the status of that now? Is it sort of simmered down, or is
No,
it
certainly.
cranked up,
There's a big importance of that, and there's the national stockpiles, the national vaccine stockpiles, that for which they are stockpiling antivirals, antibiotics, vaccines against H5N1, for example, at least seed stock vaccines. They're going to make a new one against H7N9. So that's certainly important to try to be prepared. But I think in terms of vaccines, as I said, in the future, rather than trying to make specific vaccines against individual strains, the sort of old-fashioned way, is to try to take advantage of more conserved epitopes that could be present on the virus that would allow for vaccines to be more broadly reactive.
Okay, well, I want to thank you,
Thank you.
very, very much. That was wonderful.